Hi everyone, this is Brady Ament and Michael Karaginis. We're the hosts of the Freedom Talks podcast, and we're going to get right into it, into introducing kind of ourselves and how we want this podcast to go, what we want to provide to you, the listeners. So Mike Karaginis is a renowned TMJ therapist in the US and in Canada, and we're here to provide insight into kind of the healthcare world and give you a perspective from kind of the PTs on how the industry is going, how we see how our relationships differ with different healthcare providers, and in the future we hope to get other healthcare providers on the podcast and have an open and honest conversation to give you guys a little bit more insight as to what's the background behind the care you're receiving. So I'm going to let Mike introduce himself and kind of give his background.
Hello everyone, Brady and Molly over at the Freedom Shop. Thank you for helping orchestrate and putting together our very first podcast. Bear with us, as I'm sure there will be some bumps and bruises along the way while we figure out how to best deliver some of the messages and the content we'd like to deliver. But as Brady had indicated, yes, I've been a physical therapist now for 30 years. It's hard to believe. I'm not sure where the time has gone. Over the course of my career, I guess I consider myself a very heavily based manual physical therapist, really looking to treat kind of the whole body from head to toe. And then about 15 years ago, I had the fortunate opportunity through the University of St. Augustine to really branch out away from just spinal treatment into TMJ or temporomandibular disorders, craniofacial pain, orofacial pain treatment, evaluation and treatment approach with significant instruction from Dr. Mariano Roccobato, but then really a very eclectic and progressive treatment by numerous individuals now who sort of molded and helped mentor me along the way. So I'm very excited to just be a part of this process, be a part of healthcare, and of course, as the owner of Freedom Physical Therapy Services, very excited to work with such amazing therapists and staff members to really provide top-notch quality care and compassionate care, hopefully in the way that most of the world thinks healthcare should be delivered.
Awesome. So you know you can expect honest conversations between healthcare providers and PTs, and we hope to bring an exciting dialogue to the field and to you listening. So the first thing we're gonna get to is we're going to talk about something topical. Maybe it's a research paper that came out, or maybe it's an interesting study that came out. But today, in light of the Bucks finally winning a first round playoff round, we're gonna do a little Bucks talk. And we're gonna keep this PT related. So we want to talk about Malcolm Brogdon, who's expected to be back with the team at the beginning of next week or at the end of next week. They were hoping that he was going to be able to be back for the second round of the playoffs. He had a slight plantar fasciitis tear, and I want to go through with Mike what is the purpose of the plantar fascia, and why is it such an important, or why is it such a devastating injury that he had?
All right, Brady. So yes, the plantar fasciitis, or the plantar fascia itself, for those who may or may not know, of course, runs along the bottom of our foot, and really it is very supportive in helping provide an arch to our foot, but also absorb sort of the compression or spring loading as we put our foot on the ground. And what's very unfortunate about it, for those of you that have probably suffered from it and can attest to even a plantar fascial strain or tenderness around the inside aspect of your heel bone, can be very, very painful. to the point where walking and things of that nature, or something as benign as walking, can be very painful. So imagine, right, having to run up and down the court could be a real issue. And then, of course, to suffer a partial tear would explain maybe the length of and the necessary time for recovery. You figure most soft tissue injuries like plantar fasciitis, maybe left unattended 3 to 6 weeks, might resolve on its own. Now you suffer a small tear, and that could delay things maybe out 6 to 8 weeks. So the interesting thing would just be to know, was there any biomechanical cause for this? Was it purely just overuse and the aggressive nature and the stopping and starting on the basketball court? Or is there something else subtly going on? Weakness maybe in his hip that's contributing to reduced biomechanics, significant tightness maybe in his hamstrings or his calf, or better known as the gastrocsoleus complex, all the way down. So it'd be interesting, obviously without evaluating him, we don't have any firsthand knowledge of exactly what might have contributed to this situation for him. But certainly, nonetheless, it can be very, very painful, especially at the level that they're playing.
So from what I understand, he was playing through a little bit of pain during this season, and continued to play through the pain, and eventually I think his pain threshold just was crossed, and he ended up getting imaging done, and that's how they found out about the tear. And it was kind of unfortunate because they were, he was on a roll. He was helping them secure the 1 overall seed in the NBA playoffs, and I think can you speak to how you should listen to your body when something like that is going on?
Yeah, I think kind of the mantra we have here at Freedom anyway is small problem, small fix. So my assumption would be, obviously, with the talent and the staff and the healthcare people he has around him, that they were certainly probably attentive to some of the early signs of it. But again, I think the basketball is just a very intense stop and start, compressive loading, throughout the lower extremities, the knees, the foot, the ankle, and of course the plantar fascial area, that I suspect, even with appropriate intervention, as long as he was going to continue to play at the level he was playing, it was probably inevitable that there might have been, some more extensive damage done. I think the real challenge going forward will be to help him avoid more of a chronic situation at this point. So I trust there will be, some really good, significant soft tissue work done throughout the area, especially if there's been tearing. I'm a firm believer that you need to make sure any scar tissue that would fill in there, even at the microscopic level, gets worked on through a lot of good deep tissue work, cross-friction work to help the torn fibers realign, and so that their tensile strength can be more substantial and stronger going forward, with less chance for reoccurrence, and certainly more tolerant to the continued playing of basketball. Then I'm sure they must be looking at any tightness he might have throughout that whole lower extremity, and again, as I mentioned earlier, possibly weakness throughout the hip area or his core in general, and possibly assess his footwear. Hard to know to what degree that might be playing a role as well for him.
So I did want to get into, he's going to come back, and obviously they want him to come back sooner rather than later. They're going to play the Boston Celtics in the next round. Boston kind of struggled earlier in the season, but is kind of hitting their stride at the right time. They handily took care of Indiana in their first round matchup. What's the dangers of him returning too soon? Is this an injury that if he returns too soon he'll be okay, or is it something that they need to really be careful with?
Well, when you're talking a high caliber athlete like he is, generally I think they tend to have a higher pain tolerance than most. So I think you at least need to be mindful of the fact that that he might be able to work through things that, let's say, some of us, average folks might not be able to. So I think there is a possibility that if he's also not in tune with his body and being open and honest with his healthcare team, that, again, I would just be more concerned it would be become a chronic situation that doesn't let him play at 100% capacity. Maybe he can play at 70 or 80, which, maybe that's good enough to help the Bucks be successful until the season is over, and then he's able to totally convalesce and heal the situation. So, yeah, I think there's always the concern for, rupturing it completely and even becoming more debilitated by it. But I would think, his healthcare team is certainly keeping a close eye on him and making sure that he has a safe and as close to full recovery as possible.
Yeah, I think there's that old school mantra of need to get back as soon as possible, need to help your team, and I completely understand that from his perspective, but it does seem like, especially with soft tissue injuries, that it could really be debilitating if he comes back too soon.
Absolutely, and I think sometimes we forget, we joke about the industrial worker, right, that a lot of the hard labor and work many people do out there have their own set of acute, maybe minimal injuries that can become chronic, and yet, right, we're all getting sort of paid at the end of the day to provide a service or provide care or get a product out there, or obviously play at the professional level. So I think you have to find that balance of also the expectations and just some of the nature of what goes along with each of our occupations. And in this case, especially basketball, foot injuries, ankle, knee, are some areas that are certainly at risk.
So when a patient comes in with something like this, whether it's a soft tissue injury to another area of the body, what are you educating them on in terms of what's the difference between having a tendon and ligament injury compared to something that's musculoskeletal in nature?
It's a great question. So, part of it has to do with the different elastic properties of the tissue. For example, a ligament, right, when that has been stretched or overstretched or chronically stretched, it unfortunately doesn't retighten on its own accord. So you do the best you can to allow the secondary stabilizers to help support things, and then through various different exercises and programs, neuromuscular control, try to help that joint that might have been disrupted from ligament damage improve better. When it comes to things like muscle, tendon, or the fascial area, those can be a little bit more variable, and I think a lot, in my opinion anyway, has to do with when there's been disruption to that tissue, either stretching or microscopic tearing. I think some of the discomfort that really lingers long term, again, is that potential deep scar tissue that will fill in, and when it's not appropriately addressed and treated, every time they move or tug on that tissue, I think it contributes to longer discomfort. I try to explain to patients, when you think of a scar, let's even just say a simple cut, when that tissue heals, if you don't do some intervention in there, that tissue will sort of heal like a spider web. There'll be lots of cross fibers, different directions of the scar that can form, and when you do appropriate soft tissue work to those areas, you can try and get that, so to speak, spider web appearance. You can allow that scar tissue or those to align more parallel lines, and as a result, reduce the cross bridging or that tugging on those sensitive scar tissue, and then it also improve the tensile strength. So I think there's also the mindset of just how these things will heal, and maybe what's the most appropriate intervention, whether it's muscle, tendon, or ligament, or fascia.
So another thing I want to touch on, what is he looking at? You mentioned that it might have been caused by weak hamstrings or tight hamstrings or something in the gluteal muscles. How is that affected? How are his biomechanics affected? Maybe when he comes back, if he's favoring one side or the other, or how can he expect his body to kind of bounce back from this?
Good, great question. Well, I'm going to make the assumption that as this occurred, and certainly once it got progressively worse, that his healthcare team has done a really thorough assessment of sort of the length-tension relationship of the muscles and tissues in his lower extremity, even his spinal area, his pelvis, and looking systematically through right manual muscle testing, which muscles might be weak, or actually, maybe, or just imbalanced. So I'd like to think during this time of convalescence, while he might not be on the court, I'm quite positive they're doing an extensive amount of stretching and strengthening and proprioceptive work to allow him to come back and function even better than before would be my expectation.
Do you think there's any difference between if we saw one of these patients in the clinic that isn't a professional athlete, where would they be in terms of their progression on training regimens compared to what he's doing now?
Well, I think that's always a great topic of discussion, right? Because, in the healthcare world, most of us could not afford, let's say, daily treatment and daily intervention. So when you're talking a high-end athlete or professional athlete, they're getting significant attention each and every day. Mm-hmm. Anywhere probably from an hour to 2 to 3 hours, right? So I think you can't make tissue heal any faster than it wants to heal. So I think the course or length of time to feel better and recovery could potentially be the same. But I think, also, let's say if someone happens to be a sedentary worker, working at a desk most of their day, I think the change in the care will be, if they don't have any expectations to go back to running or jumping or, stopping and starting or sprinting, that you will probably tailor their exercise regimen accordingly. So they're not going to maybe put the same demands on that foot as he's going to. So again, I just think there's just the average consumer maybe could afford 1, 2, maybe at most 3 times a week to be in for physical therapy. So again, I just think the quality of attention he's getting is obviously more intense and probably more focused than what you can maybe get traditionally outside of those services.
All right, well, we wish the Bucks good luck in the playoffs, and we're going to take a break to hear from our sponsor.
Is that good?
Yeah.
Okay. Will you be able to edit their noise in the background out, or no?
Yeah, it'll be fine. The nice thing about the mics is that you're looking at like a cloud kind of in terms of area.
Yeah. Oh, I see.
So it shouldn't.
I'm just gonna let the video run, and I'm just gonna let you cut it.
Yeah. Okay. Let me just do this real quick.
So I'm going to ask you about trigeminal neuralgia. We get a lot of it. Seems to affect those over 50 and more women than men. I'll ask you a little bit about chronic pain.
Mm-hmm.
What exactly is it? How do you explain it? What are the symptoms?
Okay.
I think they went upstairs.
They went up, okay, thanks.
Let me let's see, do I have my, I'm trying to think what I said on my blog too. I should have sort of piggyback off of my, let's see, just so I don't maybe give conflicting, not that they're probably gonna look at both or read it, but.
That is like the highest hit
I know,
thing.
I know, I feel like I wish there was, I really need to, well, I'll be at the conference next week, so maybe that I need to do another blog on that, but just come up with something new or different, or who knows, maybe there'll be a lecture there, speaking about it.
We should start charging do an online course about
Right.
trigeminal neuralgia.
Yeah.
and then I did a quick Google search, and I want to talk about. It took me like 3 pages essentially to even find an article that stated that PT could help.
Right.
This is not mentioned at all, and then there's, everything's all about, it's see your doctor, and then here are the drug interventions, and here are the surgical interventions.
Right.
Why isn't conservative treatment ever, I want to discuss that, and
Yep. So it occurs over the age of 50, boy, can you imagine it can occur in infancy? That would be weird. How would a baby tell you it has trigeminal neuralgia? Average for women, slightly less
here's
than men.
yours.
Did I do 2 of these, or have you only done the 1? Did I do 2 of these?
You did a more recent one.
My vision is getting bad. Tic de la Rue. I'm not gonna be able to say those. Oh, that one I can, but Fothergills, I don't remember, Fothergills? How do you say it? Yeah, it's an attached shirt, well, I could almost just kind of read this, eh?
Mhm.
I've done that where it goes up your nose, kind of. Oh, this doesn't expand, does it? How do I get any idea? How can I make that a little bigger so I can read it easier without? Oh, what'd you just do? So instead of touching your screen, oh, too big. Get it all to just fit barely on there. I know I got a few. I mean, that one lady that's about all her hypermobility is like, honey, how am I possibly gonna fix you with a response other than somebody's must be missing, she has Ehlers-Danlos or something
Exactly.
going on, so I guess I'm gonna have to try to find out where she lives, so I'll try to get to those tonight. When you side bend your head. Yeah. Well, let's see how it goes. How do you think you're gonna direct this one? At least this one I can read.
I'm gonna start, I'm just gonna start by, we always wanna cover a, what do we call it, like a treatment topic, or,
Yeah, so say we're gonna start with trigeminal neuralgia.
yeah,
Mm-hmm.
just,
Or tic de la Rue.
Tic de la Rue.
Tic de la Rue. Tic de la Rue. Hopefully I'm saying it right.
Alright.
And Fothergill's disease, but I'm not sure exactly. Fothergill's. That's what it looks like, doesn't it? I just made shit up.
Doesn't really matter.
I know.
As long as space
That's
gets
what I
done, it
mean.
doesn't
That's right.
matter.
Are we doing on time too? Okay, I mean Jeff will be done in time by 10, right?
Yeah.
Jeff.
Yeah.
Yeah, like 25 minutes.
Okay, let's wing it.
Alright. I'll pull it back up when we're. Alright, for our second segment of the show, we're always going to try to cover a treatment topic, and today's topic we're going to talk about trigeminal neuralgia. If you guys don't know what trigeminal neuralgia is, Mike's going to come in here and explain what it is.
Well, thank you, Brady. I will do my best. So trigeminal neuralgia, or maybe sometimes people are very familiar with the term tic douloureux, it can be considered certainly one of the most painful afflictions known to the medical practice. Sometimes has been also labeled as the suicide disorder by medical science. In general, it is very sharp shooting, lancinating, electrical type pain and impulses that you can feel in the facial area, usually on one side of the face versus bilateral, and it stems from one of the cranial nerves, particularly the trigeminal nerve, and we have different branches that can sort of control. I guess the easiest way to describe it, since we can't see each other, is possibly along the forehead area, or the cheekbone, or the lower angle of your jawbone. Would sort of be the traditional three divisions of the trigeminal nerve that someone could feel very intense, lancinating pain. It can last for seconds or up to about 2 minutes. That would be considered sort of trigeminal or type 1. There's a type 2, which might be more of an achy sensation, a little bit longer, prolonged amount of time. And unfortunately, there's no particular test. I mean, obviously, you need to go through a proper evaluation and neurological workup, but a lot of it really relies on patient subjective information as to how they're describing their symptoms versus other temporomandibular disorders or facial pain disorders that we might be thinking about.
So, I was doing a search yesterday, trying to prepare a little bit. I'm not a PT, so I don't have the expertise you do. But I was trying to just do a general search, Google search for trigeminal neuralgia. And, the first hits were Mayo Clinic, some of the top hospitals in the US, they all have articles about trigeminal neuralgia. What are some of the interventions? What are some of the treatment options? Who it affects? That sort of thing. And it took me a while. It was like the third or fourth page before I even hit an article that said that physical therapy could be a possible intervention. And I obviously get to see every day what we do here, and I get to be around you and some of the other TMJ specialists that we have at the clinic, and I see all the amazing work that you guys do for people, and people that just come in and say, I've been in pain for forever, and I can't believe that this worked, and that I feel so much better, and I didn't have to have surgery, and I'm off drugs, and that sort of thing. But the first interventions that you see online are, here's the list of drugs that you can take that can possibly help you out, and then if that doesn't work, here are the list of possible surgeries that you can have. And I guess I don't know because I've never experienced it, but if you go to your doctor, are they telling you like these are the only options, or is PT coming up in the conversation?
Well, that's a great question. I would say in general even, trigeminal neuralgia aside, I think there are just so few physical therapists in the US and abroad that have taken the additional training to treat temporomandibular disorders, much less trigeminal neuralgia related disorders. So I think part of that is the problem. It requires those of us that are doing this to continue to get out into communities and the physicians and help educate them on some of the impact that we could possibly have. But as I try to explain to patients in general, whether it's a knee problem, a neck problem, or trigeminal neuralgia, right? Depending on what healthcare professional you see, they're sort of limited by the tools in their toolbox. So, and I mean this in no means disrespect to any other healthcare professionals, right? But if you go see a physician, for example, and let's say they're non-surgical, their options are really going to be to possibly provide some of the different medications that might be able to help, maybe pass you on to a specialist in case surgery was necessary, possibly do some imaging, right? Certainly make sure there's no, any, God forbid, any tumors or any more severe condition that's contributing to this. But I would say physical therapy is probably, certainly is not well known for the treatment of trigeminal neuralgia. And of course, there's even less research to indicate any of the things that we might be able to contribute. When you do come to physical therapy, in particular, let's say, our clinic or others throughout the U.S. that have done some extensive training, I think that's where our expertise can come into play, right? So for example, we can't order medication, and we certainly can't do surgery. At least I haven't found anybody willing to be a guinea pig to let me experiment. So we're really forced to, kind of use our minds and our hands and the knowledge we've attained over the years on how to manage this. So I think, because, the cases that, I've personally seen, I would be very remiss to tell people we can fully resolve their symptoms. What I tend to see is a significant reduction in the frequency that they occur and the severity that they occur. And I had, written a blog about this on my treatingtmj.com website some time ago, and it continues to seem to spark a lot of interest. But, from a physical therapy's perspective, there's things that we can do to help with desensitization, because generally, for people who have trigeminal neuralgia going on, right, simple things that we might take for granted can be very uncomfortable for them. For example, just subtle vibration might cause a reproduction of their symptoms, or maybe when they're shaving or just washing their face or applying makeup, brushing teeth, even eating, drinking, talking, and ironically even being opposed to wind. Some of those things, because the trigeminal nerve has now become, as we call, so sensitized or easily agitated, those subtle little things can trigger the unfortunate attacks, the sharp lancinating discomfort that patients can have. So one of our goals is to try and help them manage that sensitivity, try to down-regulate the nervous system to ease with that. I think too there's some various protocols out there that people have tried with different types of electrical stimulation to try and stimulate the nervous system and try and alter it. Just put an input in that might change the output. That's the easiest way for me to describe to patients when I'm working on them. What am I trying to do? I'm trying to provide an input that possibly will change, reduce, eliminate would be wonderful, the output or the experience that they're having. Also very fortunate, a few years back, we have coming to the U.S. Dr. Harry von Piekarts, and he just has a very extensive neurological approach to treating head, neck, and face pain in general. And it's interesting, while I had a lot of these tools over the course of my 30 years of being trained, I never thought of putting them together in the manner that he and his team are instructing some of us in the U.S. that have had the good fortune of being trained by him and going through his program. So there are areas where our nerve tissue can become entrapped, either through soft tissue structures around the head, neck, and face, or in the trigeminal nerve area, as it courses from the brainstem. There are little, let's say, foramen or little holes that these cranial nerves can exit around our skull bones. And sometimes by just providing the necessary manual pressure onto the various cranial or facial bones, you can possibly just reduce some compression, irritation to that nerve structure, or possibly create just a little bit more space so there's less compression and irritation. And that the unknown is just the laying on of hands, and by creating a different stimulus that can alter the symptoms that they're having can have a huge impact. So I think that's where physical therapy can certainly help, but unfortunately there's not a lot of us out there that do it, and even less, I think, of the general public and the healthcare system is aware we have the ability to help with these situations.
So I guess if you're someone who's really struggling with this, and it sounds like even with drugs, even with a surgery, even with PT, this is something that might not go away for somebody permanently. It's something you're going to have to manage.
Correct. I think that, yes, yeah, go ahead, sir.
How am I supposed to look for care if I'm someone struggling with this?
Okay, that's a great question. Well, you certainly have the ability to reach out to us, and depending where you live, we will do the best part we can at, Freedom Physical Therapy to help direct you to someone in your area that might have an expertise in craniofacial pain, oral facial pain. I happen to belong to the American Academy of Oral Facial Pain. I don't have the website directly in front of me, but I believe if you go to aaop.org, that will take you to our website where there's a directory that will link you to various dental health professionals that have a substantial amount of training in oral facial pain, many of which are board certified. And then there's also, it's the only Academy of Oral Facial Pain that allows physical therapists. I believe there's now about 40 of us that have special credentials, CCTT credentials, to indicate we've done, sort of above and beyond traditional training, and certainly an expertise in head, neck, and face disorders or trigeminal neuralgia. So that would be an area to look into. And I think, the web is interesting. You have to be very careful, right? Because there's also a lot of misinformation. I think there's a lot of scary information. So I guess the biggest piece of advice I'd also like to give people is I feel during many of our treatments, especially when someone is dealing with something as severe as trigeminal neuralgia or any type of chronic disorder, there's a lot of fear and anxiety of the unknown. So I feel like I have to spend a great deal of time helping to downregulate just the fear and the anxiety with so much misinformation that's out there. And that doesn't help your system. All that does is sort of jack things up and intensify and worsen things, or possibly, starts to play with your psyche. And then, now we're dealing maybe with some form of depression affiliated with this. Your sleep might become disturbed, and we know sleep is a huge, issue for many people. But sleep is necessary for proper rest, recuperation, and just general well-being. So, I think that would be a place to start. And if we can help direct that, we gladly will.
Well, we'll link some of the directories that you send me in the description for the podcast. We're just trying to, I think, spread the word about some of the treatments that you can do that are conservative in nature, and that you can try before really attacking the big surgeries or getting hooked on meds, that kind of thing.
I couldn't agree more. I mean, I really struggle. I don't understand why there aren't more opportunities for people to proceed with conservative care. As I tell people, I guess one of the beauties of physical therapy is, while I might occasionally hurt someone, it's very rare to ever do harm, permanent harm, right? So I mean, yes, maybe in our first few sessions together, we're gonna flare things up, we might make you a little bit worse, but at least we know we can affect a change. And I think if we can affect a change, either for the worse or better, then that means that possibly our intervention or mode of intervention, if we can get the right formula, which again also is very unique for each individual. There is no cookie cutter response. And again, with our healthcare system, it is so frustrating to think that insurances think in 3, 4, 5, 6 visits, you're going to be fixed with this situation, and that there's a specific protocol to follow, because we're all unique human beings. We all have different life experiences, different emotional experiences to pain. Who knows what our social structure and our social support is. All those things can affect our overall outcome. So yeah, I think trying to get into somebody's good manual hands, and you know what, that might mean a combination. Not it's a multidisciplinary thing. Finding first, hopefully your physician can help at least acknowledge what might be going on. Maybe finding a really good dentist with a specialty in TMD, who hopefully will also know a good physical therapist with this experience. But we'll collaborate too with some great massage therapists. Acupuncture is a worthwhile try. So again, I think there's a great opportunity to make a significant improvement before undergoing fairly substantial surgery.
So at the very least, it sounds like there's hope for those that are suffering from this. So
Absolutely.
That's a good thing.
Yep, I think hope is very important, yes.
All right. Well, we're going to wrap it up today. If you have any questions, feel free to email info@treatingtmj.com, and we'll try to answer any questions that you might have. And thanks for listening.
Thanks for listening. Yep, appreciate it, and look forward to your feedback and responses.